Oh. So in this cancer pain, what's the concept of total pain? So sometimes you see this is all about the total pain. That means if it is say the is a very famous personality that is founded the first modern hospital is Madame Dam Cecily Saunders. So this is they extended the culture of palliative care, the discipline and the palliative develop like that. And it is a small cancer pain. If you see, she introduced the total pain. That means the cancer pain is small part of the palliative care. So total pain control is important. So what exactly the total pain is? So the pain is nothing but a combination of the four factors. So it is considered the social factor, physical factor, spiritual and emotional factor are combination of all this. That is very important. So if you see the physical pain might be combination of the comorbid causes, might be elderly or some of the disease. It might be different treatment related, or it might be a cancer itself causing different stages of the cancer that causes the physical pain. If you see your anxiety, that is loss of role or social status, loss of job might be associated with that, financial concern, worries about family, these are also taken into one as a consideration, and also they take the important role in this pain management. Emotional and spiritual, if you see the emotional, anxiety, fear of suffering, depression, experience of illness, these are the again, so that's how there has to be taking the whole soul management of multimodal treatment, very important. Spiritual, anger, loss of faith, finding meaning. So these are all associated with the cancer pain. Basically, it's a combination of all this thing. So if you see, this is, I think, the studies also in that quoted in that, so development of a validation total pain scale in Indian context or in this case. So in this case, you can see the contribution of this part. It's not only the physical pain is only 32%. However, the psychological, social, and the spiritual, they also contribute in significant amount of 25, 26% in this case. So that's why it is important. So how the pain classification can be done? If you see the pathophysiology or physiology, how the based on duration, that is, as you all know, there may be acute pain, a chronic pain, breakthrough pain, or refractory pain. So it's a very terminology that acute pain is a very quick onset, usually lasts 3 to 6 months. Mostly the chronic pain definition also lasts like that. If it's persisting more than 3 months, it is persistent. Breakthrough pain is nothing but a transient exacerbation of the pain that occurs in conjunction with well-controlled background pain. And refractory pain, sometimes it is not relieved by the available therapeutic interventions. If you see the pain physiology, how that's is combination goes through a four major pathway. That is a transduction, transmission, perception, and modulation. So what exactly happens is the same thing, that is the 1 year tissue damage or release of inflammatory markers, that the transduction phase. So that's basically combination for the nociceptors are activated, and in different inflammatory markers like norepinephrine, glutamate, substance P, they basically there is activation of multiple receptors, and this basically that's next step is important, the transmission. So once this is not activated, the whole pathway of the systems becomes transmitted to the A delta and C fiber. So as you know, the A delta fiber is the fast pain, that is myelinated fiber, and C fiber is the slow conducted fiber. So these basically transmit the pain from the peripheral to the center. So subsequently, you can see the perception. So once the pain is transmitted, the perception is associated to the limbic system, or as in both, this take in the perception might be in different systems involvement. And then finally, the modulation of the pain might be descending innervations or both combination, both final pain is in that way. So if it's the perception, is basically three systems are responsible for this. A sensory discriminator system that is mediated by the somatosensory cortex, that identify the presence, location, and intensity of pain. Sometimes the affective motivational system, this is reticular formation, limbic system, or brainstem. And the cognitive third one, that is, all these are basically involved in the perception of the pain. So this take into consideration in this case. So it is overall, if you see the pain, if you divide different type of pain in a, mostly you can see the neuropathic pain or a nociceptive pain. It might be a nociplastic pain like a fibromyalgia, irritable bowel syndrome. So yeah, as you already know, all the chronic pain conditions. However, there's the center you can see the mixed pain. If you see the cancer pain is kind of the mixed pain, that means it's a combination. It might be find it in nociceptive pain, neuropathic pain, or there's all combination mixed pain you can find in the cancer. So the cancer-related pain, if you specifically see, it might be related to a tumor-related pain, and that might be in the form of a somatic, visceral, or neuropathic component. So this all three component can be part of this. Another important component is basically treatment related pain that most of the patients going undergo. So it might be a post-surgery pain or the CPSP type of things can happen, or a new adjuvant therapy or the chemotherapy is something this patient is going on that might be associated with that pain, or sometimes the radiotherapy. These are all also the factors that can have the pain. So how does somatic cancer pain? If you see, it is again, the somatic pain is a well localized and a defined pain per sensation. It might be results from the malignant invasion of the skin, connective tissues, bone, joints. So these are contributing with the somatic cancer pain. And the tumor producing the cytokines, the tumor necrotic factor, they basically the nociceptive mediators are released. These are the trans or they activate the pain pathway. So that might be leading to a tissue damage, sensitization, hyperalgia occur. For example, suppose in cases of mucositis from the radiation or the chemotherapy or the post-surgical incision pain. So there occur might be a superficial pain or the deep pain. Superficial might be acute under the skin or cancer, you can see. And however, the visceral pain, it's a poorly localized that you already know that it might be because of the organ distension, impact on the inflammation. So these are the three component you can say somatic, visceral, and neuropathic pain. Neuropathic pain might be a nerve damage or a shooting or stuff. So basically the infiltration of the nervous system might be lead to a neuropathic pain component in this case. So it might be characterized from the peripheral neuropathic pain or a central neuropathic pain, depending on that how to you. If it's the chemotherapy, surgery, or radiation that might involve the peripheral nerves and can lead to pain. And in case of central neuropathy pain, it might be suppose a tumor component of the brain and spinal cord that might lead to a pain in that way or the pain processing. So if you see the more than 40% of cancer patients, the moderate to severe pain, they are very neuropathic symptoms that interfere with the daily activity. And the malignant infiltration of nerves and nerve damage during surgical intervention that also contribute this time. There might be direct invasion of the cancer and the resulting nerve damage. As you've seen in cancer plexopathy, the pain is very intense because there's injury to the nerve fibers or a specific distribution of that. Lumbosacral plexopathy might be also related to that in that way, might be related to the colon cancer or lymphoma. Chemotherapy most commonly can see a cisplatin, vincristine, and procarbin. These are result in the neuropathy that might be lead to pain. Most of the time you can see the bone mets occur and there is significant bone pain in a cancer like spine, ribs or pelvis or proximal femur and skull. They are the metastatic site. It might be for metastasis from a different cancer. So basically in this case, what occurs the metastatic that occur is that it goes through a four different mechanism that in this case, where the rankle receptors that basically activate the osteoclast or the bone resorption that might lead to microfracture and bone pain. There is another important thing is that the neuro growth factor or this is called the neural reprogramming that also contributes the neuropathic pain. Also, you can see the acidic medium in this case that occur might be a peripheral sensitization that might lead to pain or might be inflammatory factors that also causes might be central sensitization. So this is how the bone pain is related to all the four mechanisms that can be involved in this. So as you already said, that is a mixed pain, the component of somatic, visceral, and the neuropathic, as you already know in this. So if you see a lung cancer, for example, so how it can involve. So if it's the visceral, that is might be poorly localized from the deep, a consistent the visceral pain that might be from the pleura. Or it might be a sharp, well-documented somatic pain, might be reinvasion has occurred. So it is giving a sharp, well-localized pain. And it might be because the intercostal nerve involvement. So that might lead to neuropathic pain. So these are the three components in a single type of case. So as you can see. So there is another terminology, I can say the cancer pain syndrome. That means it might be related to the other factor, other associated thing. So it might be acute pain syndrome. So lost or what? See, where is the presentation? Hello. Mhm. Okay, so this is the cancer pain syndrome. As you said, it is an acute pain syndrome, might be related to, as you see, the patient might be undergoing biopsies or sometimes the phlebotomies, repeated phlebotomies for the chemotherapy. This also can acute pain or a post-op pain in this case, you can say. So if you see the chemotherapy induced headache might be occur, might be after treatment of intrathecal methotrexate might be receiving in the leukemia or lymphoma or like that. Or it might be a diffuse bone pain that might be related to the commonly the transretinucleic acid, or it might be related to sometimes the flare syndrome in advanced prostate cancer. So these are basically, you can see uh, different type of steroid induced perineal burning. A patient might be receiving steroid that can cause perineal burning or repeated the rapid administration of intravenous steroid. So these are the acute things that can occur. However, there also can occur the chronic pain syndrome. As you can see, patient might be receiving the hormone therapy measure that is also related to arthralgia or some of the dyspareunia or the gynecomastia. Also might be related to the radiation induced, that might be chest wall syndrome, cystitis, or again chemotherapy related pain syndrome that might be one related to maybe peripheral neuropathy or sometimes bony complications. Surgical pain syndrome, again, this might be post mastectomy pain or a post R&D dissection pain, post amputation pain. These are again associated with the cancer in that way. So not all pain in the cancer is actually because of cancer. Sometimes it might be related to the other debility induced or the totally unrelated to cancer that might be the factor. So now let's come to the cancer pain management, how it's going to manage. So as you already know how the pain occurring in the cancer pain, how it's related. So in this case, maybe what are the factors that sometimes, as already know, that sometimes under treatment of the cancer pain, it's a data from the United States might be, it might be holds true in all of the situations might be. It might be sometimes the patient related, like maybe under reporting of the pain, or sometimes the fear of disease progression might be there, or perceived lack of time or inadequate amount of time spent in physician's office to discuss the pain problem. Sometimes you're not discussing exactly the pain. Poor compliance might be to the, that might be fear of addiction. Sometimes it might be the physician related also. That means it might be lack of information, sometimes the lack of expertise in some of the strategy of cancer pain management, legal issues, or sometimes desire to provide patient the latest or greatest pain. So the evaluation of the cancer pain is very important in this case. We have a sort of physical examination, diagnosis, formulation, and you must have etiology, pain affecting your performance status, quality of life. So this is, there are different tools can be used for that, for assessing the pain. It might be, you can see the different terminology or the nomenclature for this, like Socrates that is commonly used, like where is the pain, that the site of pain, that might be the maximal site of pain, onset, character of the pain, what is the pain is like, whether it's stabbing or hacking, so that you can characterize basically whether it is somatic, neuropathic, or the visceral pain. Radiation, whether it might be radiating somewhere, time course, severity, how bad the pain is. So these are very important to manage the pain. Again, basically when you're to a scoring of the pain also, there are certain score that is unodimensional pain frequency score. So if you see the only, if you're seeing only the pain, that might be visual analog VAS scale or numeric rating skills. These are basically only take care of the pain. That means it is only the unidimensional, single dimension. However, if you see most of the time, you've seen the multi-dimensional pain scale that will lead to a thorough examination of the patient that taken into consideration, like a brief pain inventory or Megale questionnaire or promise sort of short form 36 health survey or cancer pain prognostics. And however, these are very extensive skills that can be used in. This is also one of the very important, I think, for the cancer pain, like Edmonton classification system. However, this is again takes time to fill and everything. Every time, sometimes because of the patient load might not able to fill that. But most of the time, also research purposes they are done. Brief pain inventory, short form that can also can be used. This is another, I think, man is there. He has done this study and development of the malnutrition total pain scale for evaluation total pain. Because in Indian context, this study basically reports a total pains to be a brief, I think, 18 item that valid and reliable questionnaire in the Hindi language for assessment of all the components of total pain in cancer pain. So the treatment or the management is must include the multimodality management, starting from your chemotherapy, neurosurgery, palliative surgery, orthopedic surgery, nerve blocks, treatments, radiation therapy, pharmacotherapy. So basically, it's not only the cancer surgery or the treatment part, it's also take care of the pain part. So WHO ladder, it is, as you already know, it is most of the important thing that has been started in 1986. It's a proposed strategy for the cancer pain treatment based on a sequential three-step analytical ladder. So it started on that. However, it again started with a different suggestion to improve or to change like that. Sometimes it might be initially started with the step one might be a non-opioid analgesic, step two with weak opioid or strong opioid like morphine, fentanyl, and other adjuvant. However, some of the studies also state that it might be a two-step or three-step strategy can be changed. Sometimes it has been seen that the low dose morphine, like 30 milligram per day, provided an earlier and more adequate level of analgesia for moderate cancer pain. However, it has the morphine has a role in the third step, but sometimes a low dose can be introduced in the your second step, and it has positive impact on overall well-being. So this can be done like this. So do you really need another step? Sometimes it has three steps, and then subsequently also the second proposed modification like a bidirectional, sometimes a new adaptation of the analgesic ladder. Another step is added, that is nerve block. Sometimes intense pain might be a neuroleptic block or spinal stimulators. This might be needed. So these are the fourth step, that is a more interventions or pain management that include the epidurals, PCA pump, and neuroleptic block therapy. So in this case, if you see the step up and step down bidirectional data, that means a slower upward pathway for the chronic pain and cancer pain, and faster downward direction of the intense acute pain. So acute pain, in that case, you have to start with the step 4, might be first you have to control that and then comes down. So as in this case, also you can see the strong opioid, the non-opioid, this might be moderate to severe pain. So in that case, we can see the add the intensive therapy in that way. So another important thing is that when you're managing the pain, it should be the bilateral by the mouth as soon as possible. Patient should be treated with the oral tablet by the clock. So that means patient should not go to the breakthrough pain. So it should be, or the pain should be adequately dosed so that the before the next dose, it should be properly timed. So by the clock, and also the further individual attention to the details. So these are the important factors when you are managing a cancer pain. This is very important. So these are the 4 factors that you have taken into consideration. So if the list of the drug that can be used or the pharmacology in the cancer pain, starting from the basic drugs to the alternative, it might be a paracetamol or ibuprofen, codeine, morphine. These are other adjuvant like corticosteroid, antidepressant, anticonvulsant. These are the different group of drugs that can be utilized in this case. So first of all, you can see a non-opioid. If you see the paracetamol, the very important drug, one of the very common drug that can be utilized in a dosing like this, might be diclofenac or a brufen. But the no, if you see the sometimes the combination of the acetaminophen and NSAID in along with the opioid may improve the pain control. So individually it may not control the pain. However, along with the opioid, if you add on paracetamol as an NSAID, it might improve the pain control. Tramadol, if you see it is a centrally acting analgesic with the mu opioid receptor activity, also have a weak effect on serotonin and norepinephrine reuptake inhibition. That is the descending pathway. The modulation pathway is also a tramadol used. So that's why it is one of the very common drug that is used. And it's used both parent drug and also the metabolite. It might be that very careful sometimes because concurrent serotonin therapy might risk of serotonin syndrome, might seizure can occur in the patient is taking SSRI or TCA concurrently. So sometimes these are some of the opioids that initially used. Now it is more or less not used nowadays, like pentazocine or reducin. Might be because this has a reverse the mu analgesia, and sometimes it also presents physical withdrawal symptoms. Strong opioid pills, the morphine is the most widely available, and it is the gold standard against which other opioid analgesics are measured. So if you see the oral morphine, it's the most mainstay of analgesic therapy in the patient treating with the moderate to severe pain. So if you see the general principle, there is no single optimal maximal dose of an opioid analgesic drug. The patient really benefits from the combination of different opioid in given suboptimal doses. So that means the dose is very important. So it is very important to recognize that there is significant interpatient variability with regard to the responsiveness to different opioids. So that means the patient will respond poorly to one opioid, may respond to the other. And sometimes the long-term use of opioid is controversial, and it can assess, monitor, modify, and sometimes also the modify the dosing also. If the morphine is the principal medical alkaloid derived from the poppy plant, it's a pure agonist that act on the opioid receptor in the brain and spinal cord. and its metabolism in the liver in the is 3 morphine glucuronide and 6 morphine glucuronide excreted in the urine. That's why sometimes you have to be careful in the patient the renal dose. However, there is no ceiling dose, and it's morphine tablet. If you see in the practical use, there is a immediate release tablet and another is a sustained release tablet. So normally we start with the immediate release tablet that start with the 5 to 10 milligram 4th hourly. So you might be starting in the 6 a.m. in the morning to 10 a.m., 2 p.m., 6 p.m. and 10 p.m. And night dose should be double the dose so that there should not be any breakthrough in the night. Sometimes you have to be careful when the patient is cachexia or the comorbid. So this time the 4th hour dose to be increased 50% every 24 to the pain really adequate. So this how we can just monitor the patient, how the morphine requirement can be monitored. So once the patient is on immediate release pain is controlled, that it can convert to the morphine sustained release tablet. So based on the how much immediate release tablet and how much the morphine is requirement, so that is divided into twice dose. So half of this dose can be other twice dose. It might be divide can be divided into sustained release tablet. So what is the role of the parenteral morphine then? Sometimes the patient might be intense pain, or sometimes patient present a severe pain that needs urgent relief, who cannot swallow, or there might be nausea, vomiting. As so suppose that those at the end of the life were unable to continue the oral medication because of weakness or debility. So in that case, might be a IV morphine or subcutaneous morphine have a role in that case. So sometimes if it's considered IV morphine, suppose it might be in this case. So if you see in this 1.5 IV start given every 10 minutes for rapid titration in case of severe pain, and then effective within an hour in most of the patients. So that's how we have to monitor in the monitoring setup. You can just use IV morphine in this case. And this is a very good algorithm for the management of the patient in the morphine in this case. If you see a patient is having acute pain, suppose the patient has a cancer pain and then start with the acute pain, a chronic, acute and a chronic pain. So you must assess the pain, the comprehensive pain assessment is there. So if the patient is a morphine naive patient, then in that case, you can start straight away go with the IV bolus of morphine. So 0.05 milligram per kg body weight, followed by infusion, you can start. Suppose the patient is already on oral morphine and then or opioid tolerant, and then he's a acute and chronic. Then in that case, again, same bolus followed by the, according to the dose of what is the conversion dose of oral morphine that he's taking, it can be used. And then you assess for the every 15 minutes the morphine pain. And depending on that, you can use or change your planning. Suppose if the NRS unchanged or compared the baseline, then you can double the rate of morphine infusion. If the NRS is more than 4 but less than the baseline, then you can just 50% increase the morphine. And if it is less than 4, you can continue the same for 2 hours. Then again reassess the patient every 15 minutes. If the persistently the pain is less than 4 per 2 consecutive hours, then you can stop the IV infusion and convert the oral morphine in the ratio of 1:3, sometimes 2.5. So these are the basically the conversion that you normally use. So these are the, you can see the revise in this case, the mild, moderate to severe pain, how starting from the NSAID and paracetamol to the weak opioids and the strong opioids, and then interventions based on that. Also, you have to be careful about the adverse effect in these cases because remember it might be sleep disturbance, constipation, nausea, vomiting. If you see the opioid-induced constipation, was the very common constipation that is, I think it may be because of the increased fluid retention, there is electrolytic secretions, there is decreased GI motility in this case that leads to constipation. However, the opioid institution is not dose dependent, so it is not elevated by the dose reduction. So do not develop the tolerance to OIC. So in this case, we have to use the laxative in this case, and the combination of the persistent constipation might be used in that. Nausea, vomiting also can be taken care of the specific or anti-emetic agent in this case. Pruritus can be antihistaminic, and that's why if it is significant. Opioid-induced neurotoxicity can be there, so it might be morphine or codeine is active metabolite that is causing, or older adults might be renal dysfunction. So in that case, you have to be careful regarding the neurotoxicity. Might be depressions. So sometimes naloxone can be utilized for this. If those who are OSA or the obese patient concomitantly using that. Sometimes the transdermal fentanyl in setup can be utilized like a selective mu receptor agonist. It's available as 72-hour transdermal preparation, the dose of 12.5, 25, or 50. These are the different preparation that's available in the for the use. And However, when you're putting a patch, it normally takes 12 to 24 hours to. So initial part when the breakthrough pain is there, in that case, OPD is necessary before starting. So during the first 24-hour application. And also in this case was taken out also the depot also remains for the skin for 24 hours. So they accordingly have to manage this patch. And the poor absorption, this cachexia or hyper. So in that case, we have to think of might be poor absorption. So depending on how much oral morphine is taking, it can be might be converted like that. If it is 30 per day, it's 12.5 microgram per hour, and if it is 240 milligram per day, then 100 micro per hour. So the other, you can start the transdermal fentanyl depending on how much oral morphine he was taking. Buprenorphine patch, it is again a potent partial agonist for the mu opioid, available in different preparations. However, this mostly chances of QT prolongation is there, so you have to be in that case. Methadone, again, synthetic opioid available as a tablet in suspension. It's less frequent dosing, lower cost. It might be a good extra, but another NMDA receptor inhibition is very important action in this case. Also, you have to think of the adjuvant like steroids, antidepressant, anticonvulsant, and in those cases, only the opioids are not only them can just take care of the pain. So in that case, also you have to take care of the other adjuvant also. So I think most of the things that you have tried to cover up, and there are so many other things also that is in the whole pharmacology part, apart from the I think side effects, adverse effects, management of the pain. So I think the next part is the intervention that is also very important when the patient acute pain, and I think that will be taken care of the ma'am. So Madhuri ma'am will take care of the interventional part. Thank you. Hello.
Anyone wants to ask any question on this topic? Hello?
Hello.
Hello? Anyone has any questions on this topic? Hello? Thank you, Devesh. Thank you very much.
Thank
Very
you.
nice presentation. I just want to say that Devesh has given a lot of important aspect of cancer pain management and cancer pain. And this is with my own experience, as well as one of my PhD students, she did thesis on this topic on cancer pain. And when we were finding out, the topic was that how much component of cancer pain is physical pain. So when we think that cancer pain is so severe and excruciating, and patients are screaming, howling, and crying, but the component of cancer pain, physical pain, which we found is only 35%. So rest 65% component was psychological, social, and spiritual. This study has been also published Indian Journal of Medical Research. So this is important, that how will you handle the other component? Other component can be handled only by your empathy, by good communication, and by giving extra time to the patient. Because most of the time when cancer patients are coming, they are full of uncertainties. Uncertainties towards the treatment, uncertainties towards the life, and uncertainties towards many other things. So it is not that we are going to give them everything, but your patients listening, giving them a realistic hope of the treatment plan, if you have understood well, and giving them an honest information will give them a lot of hope and will give them a lot of confidence on you. So this is important, that besides learning pharmacotherapy, intervention, non-pharmacological therapy, and in non-pharmacological therapy, which works the best is your patients listening and giving them the realistic picture about the disease. What are you planning to do? How much they will be relieved? I have seen a lot of neuropathic pain patients also in cancer patients, especially chemotherapy-induced neuralgia. By giving them any medication and telling them that you will be all right is wrong. Rather, this we should say that this is a pain which most of the time will not be able to reduce completely, but definitely we will keep trying and give them a hope of diverting themselves and making them keeping them busy with other things. So they will start realizing that this is part of life. So rather than loading them on medication or giving them a lot of medicines and blocks, which are sometimes works, and disseminated pain, which may not work, giving them the realistic picture is the best answer. So, Devesh, you have given a very good overview of cancer pain. I have a lot of things to say, but I think it's already very late.
Yes, ma'am.
So maybe next
No,
time sometime.
we
Thank you
we
very
have got
much.
one more lecture to go.
We have one more lecture.
Yes, I'm supposed to look into the interventional pain management for
Oh,
cancer.
so I just thought that it's over. So, Dr. Madhuri, can I leave because I have some
Certainly.
other. Okay, thank you very much.
Thank you so much, Sushma.
Thank you, ma'am.
Thank
Thank
you.
you very much.
Thanks.
Dr. Boi, can you stop sharing your screen and then I'll try if I can share mine?
Yes, ma'am. Yes, I'll just stop.
Okay, while we are organizing ourselves, I must say that this topic is a huge one. So today what I'm planning to do is I'm just going to give you an overview. Dr. Boi, can you stop sharing your screen, please?
I think it takes the option is not coming. Ma'am, I think it is showing like multiple participants can share simultaneously. You can start share, ma'am. Automatically it will go. It is the stop sharing is not seen here.
Okay.
It has been posted as multiple participant can share simultaneously. So I think you can directly share.
Let me try again.
Because from my side, it is not showing anything to stop share.
Okay, can you see my screen? Okay, they can
Yes,
see my application now. That's the message I got. Okay, so let me try and see if I can get it into slideshow. Is it okay now? Should I proceed? Dr. Devish? Okay, all right. Thank you so much. So basically, as the time is running out, I guess that is what is happening for most of our programs because the topics are pretty vast and we are starting late at night.
Exactly.
So now what we are planning to do is I want to give you an overview of many of these procedures which can be done to relieve pain in cancer. Like Dr. Devesh has already given us this step ladder, which was a recent addition, in which the fourth step of interventional treatment has been added. Not only that, there is this step up and step down approach. So that doesn't mean that you have to go climb from step 1, 2, 3, 4. What you can do is you can just to get control on the severe acute type of a pain, you can try intervention, stronger opioids, stronger medications, and then slowly step down where the patient is most comfortable with least of side effects. So that is the beauty of this step ladder now. So it can go both ways, and so you should not hesitate to offer interventional pain management initially also. You don't need to undergo all sorts of uh, trying out various drugs and tempering their dosages, etc. So in say supposing in case of say pancreatic cancer, we all know that there is a severe abdominal pain, and this can be controlled very nicely with sympathetic blocks. So giving a celiac plexus block and then giving him other treatments might be a more prudent thing to do, so that he doesn't go on very high dosages of painkillers. Now the advantages here are, usually these blocks are most useful for persistent and intractable abdominal pain in cancer. And now it has been reported beneficial to manage not only pain but also severe nausea and vomiting, because as we know, once you block the sympathetic pathways, then the parasympathetics take over, and therefore the forward motion of food also starts. So that will reduce his nausea and vomiting, and it will help with passing the food onwards, and so the chances of constipation with other medications. So severe uncorrectable coagulopathy or thrombocytopenia because of his other chemotherapy agents, they will risk bleeding. So do not take that risk. Always get the fresh PTINR and other coagulatory parameters before you handle these patients. Second is sepsis. If they have got any type of secondary sepsis, do not go in for any kind of intervention. Now, the celiac plexus is very close to so many vascular structures that the neurolysis will be contraindicated in case of abdominal aortic aneurysm, aortic mural thrombosis, or any eccentric origin of celiac artery. And it also has got effect on bowel motility. Therefore, if you are suspecting that the pain in that patient, the abdominal pain could be because of bowel obstruction, even partial obstruction, do not attempt sympathetic block. Any anatomical distortion, if you have seen the CT scans, if you have seen the MRIs, if you have seen even the PET CTs, and they are showing that the entire anatomical structure is completely disturbed, then be very, very careful. That's a relative contraindication. If you are doing the procedure under CT scan, like I do, then at least you have some idea about where the needle is going. However, if you are going to use only the fluoroscopy, then you will not see these soft tissues and you might end up with bigger problems. There are multiple interventional pain management procedures. So they could be just a local steroid with neuroaxial blocks, just as diagnostic cum therapeutic. They could be pump implants, they could be neurolytic spinal blocks, they could be radiofrequency ablations like in Splanchnics, or you could have vertebral procedures, kyphoplasty, etc. In the old days, the morphine was not so report, or just putting sleep and giving continuous infusion. My apologies. It seems like I was dislodged. So I'll start sharing my screen again. All right.
You can see, ma'am, your slide.
Yes, thank you. So I'll jump into the neurolytic MIPSIs. This is instead of using terminologies like block, we are using MIPSI, that is minimally invasive pain and spine interventions. So when we are using the neurolytic agents, what we are actually doing is we can use either ethanol or phenol. So basically, like I mentioned, you can use either ethanol or phenol. Now, ethanol is more common because it is more freely available. It causes precipitation of lipoproteins and mucoproteins. The viscosity is much lower. The effect of injecting ethanol, you must have seen if you have done neurolytic blocks, there is a transient severe pain complained by the patient when you are injecting initially. The spread is more diffuse, the destruction of the nerve is more intense, and onset of action is much faster. In phenol, which we use between 3 to 20%, it is less commonly used because it is less freely available. It's not a very stable compound. So either you have to get it, if you are making aqueous phenol, it is very effective. However, you have to make it instantly just before giving the block. Otherwise, it can be used either mixed with glycerol or it has to be specially formulated so that it will last a little longer. Protein coagulation and necrosis of neural structure is the mechanism of action. Viscosity is higher than ethanol, and there is no pain on injection because it has got a local anesthetic effect. It is less diffuse, less intense, and the onset of action might be slower. Now, we do not do any blocks without some kind of a guidance. Fluoroscopy is something which we are most familiar with and which is most common. It is very, very simple to perform because we are trained on that. The disadvantage is anatomical structures are overlapping. You are basically looking at the bony structures and the soft tissue is not so well seen. I mean, sometimes you could see the shadows, especially of the diaphragm, but unless you are putting the dye in, it's very, very difficult to see other structure, even vascular entries. And so it does not allow distinction between pancreas, blood vessels, tumors, or any of the soft tissues. Ultrasound again is being used more and more in the practice. It is simpler than fluoroscopy and you avoid all the radiation. However, it is very operator dependent. And retroperitoneal organs, especially like pancreas, they are not clearly identified and you do not see how the dye is spreading. For that, because that you only see under fluoroscopy, many of the people are nowadays doing a hybrid technique. They use both fluoroscopy as well as ultrasound. Finally, what we are using nowadays is the multi-detector CT scan. The high contrast and spatial resolution, it really makes you give a three-dimensional picture, especially in a distorted anatomy, like in advanced cancers, because as pain physicians, we see our patients in a far advanced stages, all the surgery has been done, the chemo has been done, and usually in that stage, the patients come to us. So therefore, it is very, very easy if you're using a CT to see where your needle tip is, how the dye is spreading, and therefore you avoid many of the complications which are mentioned in the literature all over. Radiation exposure to the patient is one of the major things. Secondly, in the CT scan, you are not seeing the real time picture. So you introduce your needle or withdraw the needle, then you go outside, take the scan again, and then do your procedure, start on with your procedure. However, with practice, it gets much easier and it is far more satisfying. The MR imaging and endoscopic ultrasound, these are not practiced by the pain physicians. Pre-procedure, first and foremost, you have to get a detailed consent after explaining the technique, the complication, effectiveness of the treatment. Don't tell the patient that your pain is going to go away. It rarely does. Usually we always talk about 50%, that you should get at least 50% of pain relief with this particular block. If you don't get it, then we'll try something else. And if you get more than that, it's a bonus for both the doctor as well as the patient. So the realistic expectations must be set before you undertake this procedure. Informed consent, lab investigations, especially the bleeding profiles. Because these patients could have had some kind of a chemotherapy, they could be having deficiencies of various things, they could be having some comorbidities and taking other medications. So PTNR is you are coming from then you the so the dye is going to, I'm sorry, the connection keeps losing. So the dye is going to spread anyway. So whether you put your dye in the retrocrural space, antrocrural space, or transaortic, or you are coming from anteriorly, like some people are doing under sonography. So basically, you need to get your drug around the celiac plexus, and the best location for that is going to be between the origins of celiac and the SMA. That is where if you put your drug in, you're definitely going to get the action. So like I have mentioned, there are many approaches. You could try any or all, whatever you're comfortable with, and try to do minimum amount of damage to the rest of the viscera. When you're doing it under Siam guidance, we really do not know the path of the needle that you are going to put in, whether the kidney is getting pierced, whether there is any tumor, whether because of the tumor the vessels have shifted their place. None of it you know unless you put the dye in. Another complication in celiac plexus block is the artery of Adam-Kivis. It is in 80% of the patients, it is going to be on the left and at the level between 9 to 12th rib. And it arises from the radiculomedullary branch of the posterior branch of the lumbar artery. So like you can see here, any blockage, any damage to this artery, or if you put your alcohol somewhere inside here while you are coming from the back, then that is going to cause spinal infarct and it might lead to paraplegia for the patient. Another thing is that avoiding pneumothorax, because at the level in which you are going between D12 to L1, under fluoroscopy, it is very difficult to see how the lungs are moving, because see, lungs are basically a mobile structure. Patient is going to breathe in and breathe out. Especially if you are going to injure him, he's going to take a nice deep breath. So make sure that there is no pneumothorax. If you're doing it under CT, you see this structure. If you're not doing it under CT, then ask the patient always to exhale before you put your needle inside. Like I mentioned, there are going to be multiple approaches. So you have a retrocrural, so you have behind the aorta approach. Now you can see such a huge tumor is out here. So if you want to do the regularly under C-arm guidance, it is very difficult. You can see the dye spreading very nicely even with a single needle technique. Then the needle could be in a different position anywhere. So retrocrural, antrocrural, wherever it is, it ultimately going to reach your plexus. A splanchnic block can be done under fluoroscopy guidance, and that also gives excellent results. If you have already seen the scans beforehand and made sure that there is no other structure obstructing your path. Some people occasionally have done USG guided blocks also. However, I personally have got no experience of USG guided celiac plexus blocks, but they seem to be traversing quite a few structures to reach your target. So I think that's a more very invasive kind of a procedure. The common side effects would be orthostatic hypotension, diarrhea, rarely paraplegia, because I mentioned about the artery of Adam-Kivis. Local toxicity if the dose is not calculated properly, or if there is any arterial or venous dosage which is going. Spinal or epidural injection if the trajectory is not correct. Aorta or vena cava puncture. So long as the PTINR is normal, then this should not cause much of a problem. Retroperitoneal hemorrhage, but in case of some people, if you see any hemorrhage coming out, then you abandon that procedure. Pneumothorax, of course, I have already shown you. And organ injury, because if under fluoroscopy you do not see the structures you are penetrating, then you might have bleeding through the urine, noting down injury to the ureter or injury to the kidney itself. Superior again, the large bowel distal to the left colonic flexure and all pelvic organs 5 and S1 disc. Again, the retroperitoneal space is free, so your drug is going to go up and down. Just make sure that around the L4 lower border, your around the L4 lower border, your aorta is going to get bifurcated, and after that you do not have any vessel coming in your way. So even if you want to go anteriorly, you could do the same thing. So multiple ways, I have tried it in my practice also. Nowadays I go anteriorly through the under the CT scan guidance, because it's a pretty straightforward thing. You put the markers on top of the tummy, you select the slice which is the best for you, and you can go directly in. Posteriorly, of course, you can go, but the direction is not two-dimensional. The direction is three-dimensional, because you have to start above, because this organ is going to come in the way when you try to introduce the needle directly. So you have to come from above downwards as well as posterior to anterior. So make sure that you have the dye injected and see the dye spread, that it is doing quite well. The ganglion impar block is right at the end. It is a single block. It is a single ganglion sitting at the end of your trunk of sympathetic afferents, and all these perineal, distal rectum, anus, distal urethra, vulva, and distal third of the vagina, all the fibers coming from them are converging onto the ganglion impar. So you can either do it is located in front of the sacrococcygeal junction and under CT scan, like I mentioned. So under fluoroscopy, you can go and see the spread of the dye, make sure that rectum, if it is connected, especially patients who have received radiotherapy, the entire thing is fibrosed and the normal anatomical planes may not be there. So take care in these patients, especially they have received radiation in that part of the thing. You are better off taking a CT scan first. So what you are doing is you are entering through posteriorly and through the coccygeal membrane. When you sacrococcygeal membrane, when you enter inside, then the dye spreads on both the sides, and then you can inject your medication. And you can be sure that you are not injecting the medicine into the rectum or rectal wall, because that is again going to cause necrosis. Side, and dye goes up and down. Blocks, apart from for the orophyseal trigeminal block, depending upon which division is involved, it also gives like it not only gives pain relief, but it also can give you some time to cause like jaw opening if it is limited. Then after the pain is gone away, at least to some extent, then you can try various methods for increasing the jaw opening for these patients. Intercostal block, of course, you can give, and neurolytic intercostal block gives excellent relief in lung cancers. There are advanced pain procedures. I'm not going to get into the details, but we'll just mention them. The vertebral augmentation techniques for vertebral metastasis. So these have to be undertaken by expert people, and we are going to have separate lectures for this because it's a very important and a very complicated procedure. The complications are also there, so one has to be very, very careful before undertaking these advanced procedures. A patient of mine had this malignant spinal nerve sheath tumor and nothing was working for him. Oral morphine we started, but when we started increasing the dose went above 100 milligram. He started having all kinds of side effects. So we decided to offer him the implant. And finally, when we put the implant inside, again, this is going to be a separate lecture by itself. So I'm not going to go into the details of it. But under fluoroscopy, you have to put the implant inside and then you can fill it up with whatever combination of the drugs, just morphine, or if it is below the level of West, then you can even put little bit of local anesthetic to give relief to the patient. Now, this particular patient could not, I mean, there was all kinds of fibrosis and everything, and he was sitting up all the time. So even the refilling was becoming a problem for us. And in this particular position, we had to refill the pump as and when required. There are multiple complications of IDDS also. So make sure the life expectancy is more than 6 months if you are planning such expensive and such invasive procedure. Infections and everything, they have to be recognized, and medication side effects, they, I mean, same as giving opioid through any other route, like pruritus and nausea, vomiting, constipation can occur. However, the dosage is much less, so we see less of these side effects. All right, so now actually, is everybody awake? Should I continue? I think you're the only one, Dr.
Yes,
I-
ma'am.
Yes, ma'am, you can continue.
Yes,
All right.
ma'am.
So now actually we are going to do this as an after test for both my lecture and Dr. Devesh Bhoi's lecture. So now in case one, this is a 65-year-old gentleman who was a known case of CA prostate with meds. And this patient had continuous diffuse pain in abdomen and pelvic region. He was receiving morphine 20 milligram 4 times a day, Buscopan 10 milligrams, NSAIDs, paracetamol, lactulose, metoclopramide, pantoprazole. So we give therapy, and then just to counter the side effects by our therapy, we are giving other medication. Patient still kept complaining of pain, severe nausea, occasional vomiting, and so he was referred for sympathectomy to our pain clinic. Now what we did was the patient underwent celiac plexus block under CT guidance and reported 70% reduction in overall pain. The dose of morphine was reduced to 10 milligram 4 times a day, and that was drastic improvement in nausea and vomiting. So what we have found is there is a there are many papers which say that you can give multiplexus blockade because the tumors usually go out of the range of their particular anatomical planes, and therefore if you are going to combine, like this particular patient had received superior hypogastric plexus block before, I forgot to mention that in the history. And so what happened was he still kept having this pain and thing, and it was not following that below the umbilicus, above the umbilicus demarcation. So by giving celiac plexus block, we added on to his superior hypogastric plexus block, and so together we got much better pain relief. So here the take home message is that in case only one block is not helping, you can definitely repeat the same block, or you can try with another block as well. This is what worked, and of course CT guidance for the procedure helped because there is a precise location of target. Additional block, always keep in mind. Now this is a 60-year-old lady who had history of CS cervix with metastasis. She was brought to the emergency by the relatives, and she was already put on tablet morphine 10 milligram 4 hourly just one day before for severe pain in lower abdomen and back after NSAIDs and tramadols had failed to give relief. Tramadol had been tried only for 2 days. Now she developed drowsiness and nausea initially, then had irrelevant talk and hallucinations. Initial assessment in emergency department revealed signs of meiosis. Patient was gazing vacantly, talking irrelevantly. However, cardiovascular and SpO2 were within normal limits. Then blood gases, all the blood investigations were sent for. Okay, so what do you think we should have done in this case? Anybody?
And we should have started morphine at a lower dose, maybe 5 mg.
Okay. So what is the diagnosis?
Opioid toxicity.
Okay, that's good. Anybody else? Somebody wants to add to that?
Ma'am, we should have calculated like equivalents, morphine equivalents from the tramadol he was getting, and then we should have converted accordingly. That would have resulted in less toxicity patient.
Correct. I'm very happy that all of you had a absolutely pinpoint this thing, because you see what, sorry, somebody is saying something. Go ahead. Anybody want to say? Can't hear you, ma'am. Okay, let me start sharing again. I think something happened to my share.
That's why just that time.
Why does it go away? Dr. Bhoi, can you
Yes, ma'am.
diagnosis here, because I'm unable. Is it because it's 10 o'clock and
Ma'am, your screen is visible and you're audible also.
Is it? It's not visible to me for some reason.
Your screen is visible, ma'am.
All right, then I'll just continue. So both of you are absolutely on dot. No, but if I say share, then I can't. I want to go ahead.
Ma'am, possibly your internet connection is slow, that's why.
I think what I'll do is I'll go off and see if this helps. No, it refuses to. Okay, let me leave and come back. I just had a couple of more cases actually here.
I think it is 10:30, so maybe it.
Okay, I'm back. Let's see if we can continue with this. Okay, just last two questions and we are done. So case 2, we have already, so case 2, we already said that it is because proper titration was not done. So there is inter-individuality, because many a times people say that morphine has to be given every 4 hourly, which is not at all the case for everybody. So in Indian individuals, we always start with 3 times a day, observe them, and then slowly increase the dosage. And like Dr. Sumit had already mentioned very correctly, that there has to be enough trial given to the earlier drug, and then you have to calculate the dose from the earlier medicine and medicinal dose. So consider reduction in using tramadol. The dose of tramadol is 400 milligrams, but for Indian, we use it for 300. I mean, if 300 effect has not come, then we try to use something else. Case 3 was that of 55-year-old gentleman. He had a history of, he had completed chemo and radiation. The pain was well controlled on tramadol, paracetamol combinations. Past history, heavy smoker. He was taking Telma for his hypertension. Came with increasing low back pain with radicular pain in left leg. Occasional tingling numbness. No history of loss of control over bowel and bladder. On examination,